Paolo is the Associate Director for Consumer Affairs at the Federal Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration. That's a big mouthful. In the U.S. Department of Health and Human Services. In his capacity, he directs the precedent-setting activities in addressing consumer participation in education, issues of discrimination and stigma, rights protection, and mental health policy. Paolo, thank you very much. If you'll come on up, and then we'll be passing out cards for questions and collect them around 5 or 10 after 1, and then we'll have time for questions and answers.
Okay, thank you, Bob, and I want to also give a special appreciation to all the organizers of this wonderful event, and also a special appreciation to all the work that you folks do at the college and university levels. It's very exciting for us from Washington to see what's happening over the past 5-10 years on universities and colleges, and where change is really going to happen in terms of trying to transform mental health care in this country really starts with each of us, but particularly the exciting work that you folks are doing at the college and university levels. Let me start by saying a little bit more about myself. In addition to being a bureaucrat in recovery, I am also a mental health professional. I have a master's degree in social work, as well as a family member. Most of my immediate family members have suffered from mental health problems of one sort or another. My personal heroine is my mother, who was hospitalized in a state hospital due to major depression, was subject at that time to insulin shock therapy, electroconvulsive therapy, many other medications and procedures. Today, my mom is a professor at a local community college where she teaches philosophy and sociology, published poet and social activist, and is a real model of recovery and, again, my own personal heroine. I'm also a self-described mental health consumer myself. And my own personal experiences with mental illnesses began in the 3rd grade. So it's pretty young. And at that time, I'm sure some of my teachers noticed that I was very withdrawn as a child and was taken out of the class and told that I have to go speak with a psychologist. And what struck with me about that experience all the way to today was the ridicule that I experienced from my peers on the way home in that school bus that night, pointing at me and laughing. What's wrong with you? Why were you taken out of that classroom and told that you had to speak to a psychologist? And, feeling that firsthand experience as a 3rd grader, the impact of stigma then stuck with me for many, many years. And in many ways, that experience kept me from receiving mental health services for 10 years. My own personal family, my father was a child psychologist himself, and while a good clinician, he was a so-so father, an alcoholic in denial, who passed away about 10 years ago. My own personal journey, again, really with mental health problems, took a turn for the worse when I entered my college years, as many of us do. And I went away to school for my first semester to this college, and again, very depressed, withdrawn, isolated, no friends. And, I heard about this college counseling center on campus, and in particular, they were having group classes to deal with these issues, and I was 2 minutes late getting there, and the group had already started, and they wouldn't let me in. I never went back to that counseling center again and left that semester after one semester there. I then transferred to a urban college who will be nameless to protect the innocent, where I went to a school of social work. And again, you'd think a school of social work, again, this was 20 years ago, but you would think a school of social work, there would be a bit more understanding and appreciation of what someone might be going through with their problems. And I can remember myself hiding underneath the stairwells of the classes before coming to class so I wouldn't have to interact with people. I remember not getting up during days at a time, just lying in bed. I can remember I had my own plan for my own suicide, where my plan was to jump in front of a subway train because it would be quick and painless, and that would be it. Again, I went to the local counseling center. They had a waiting list of 2 months to talk to a counselor. Lucky for me, I saw a flyer in the hallway of the work-study program for a local mental health association that ran support groups. And through my peers, through that self-help group, I learned in terms of education, given the theme of our conference. I learned, most importantly, that I was not alone, and that stigma that I had experienced was something that many other people also experience, along with having a major mental health problem. In many ways, it was a sense of belonging, a sense of community that I finally kind of came home in a way. But I hope, 20 years later, that the work, again, that you folks are doing in colleges and universities, that what I experienced in those counseling centers and in those programs certainly has changed. And that's my sincere hope. I'm going to quickly kind of go through the slides here and talk a little bit about what we're doing at the federal government in terms of addressing discrimination and stigma. And again, terminology and words are important. They have a lot of meaning. As you can see, we use both words, discrimination and stigma, when we talk about this issue. And this was through feedback that we heard from consumers and family members, that it's important to address both the discrimination as well as the attitudinal stigma that we experience. For just a little bit about folks who are not aware of what SAMHSA is, I hope everyone is, but SAMHSA is one of about a dozen different agencies within the U.S. Department of Health and Human Services. We're a relatively new federal agency, only approximately a dozen years old. Annual operating budget of about $3 billion. As our name implies, we have our focus is both on mental health as well as addictions. Where I work, the Center for Mental Health Services, and then we have two sister agencies, centers that focus on substance abuse treatment and one on substance abuse prevention. Our prime function, and these are some of our major activities, but we issue a fair number of grant announcements. If folks, again, particularly interested in applying for grants, I will make mention of 2 ways that you can find out about information about grants. We just 2 weeks ago issued a $24 million grant announcement to try to help change mental health systems on state levels around the country. And you can find out information about our grants, all federal grants, first of all, through grants.gov. www.grants.gov lists all federal grants. It's a new centralized resource on grants from the federal government, or at our own particular website, which is samhsa.gov. Our own work in terms of addressing stigma and discrimination, really, we began to really look at this in a more strategic way after the release of the Surgeon General's report in 1999. There's a quote from Dr. Satcher there in the report where he stated that stigma must no longer be tolerated. As a response to that, we organized a meeting in 2001 called Spring to Action, where we brought together Dr. Satcher and about 400 different community leaders, researchers, providers, consumers, and family members to talk about the state of the art in terms of addressing stigma and discrimination. This is one quote from our closing speaker. "Stigma thrives in silence. We must talk about civil rights to address civil wrongs." We came out of that meeting as well with 2 clearly identified needs. The first was the need to have information about what works in terms of addressing stigma and discrimination in local communities. And secondly was the need to do more research to really prove what are effective approaches. The third major driver was the release in 2003 of the President's New Freedom Commission on Mental Health's final report. How many people in this room are familiar with the Commission's report? Show of hands. Not enough. This is a copy of the report. It's entitled Achieving the Promise, Transforming Mental Health Care in America. What this presidential commission, and this is the first in 25 years that we've had such a commission, found was mental health, not surprising to anyone in this room, that mental health care in this country is in a shambles. And this presidential commission called not that we can no longer just do reforms of mental health care in this country, we need to transform it wholesale. And so they issued this report and a set of 5 goals for us to focus on in terms of addressing how we can transform mental health care in this country. And that's really the driving force for us at SAMHSA at this present time. This is a quote from President Bush when he announced the commission, that our country must make a commitment. Americans with mental illnesses deserve our understanding. Finally, in 2004, in our appropriations, we received specific dollars and languages by Congress to help support a national anti-stigma campaign that I'll talk about in a few minutes. Here's a few other statistics. Some of this Pat talked about in his remarks this morning. This was from the MacArthur Mental Health Module. Found, again, this was the comparison between in the 1950s and to today about public attitudes, that overall the public has a greater scientific understanding of mental illnesses, yet that social stigma remains unchanged. That the public as a whole are able to distinguish between mental illnesses and worry, that the causation of both a mix of biological and psychological stress, but that, and this is key, that the belief that violence associated with mental illness has nearly doubled during that time period. Again, as Patrick talked about this morning, the issue of violence seems to be really at the central part of why, in fact, stigma continues to persist in this country. The Surgeon General's report also reiterated that main finding around the myth of violence. Again, as Patrick noted this morning, that the perception versus the reality about violence, that overall it's relatively exceptionally small, generally not statistically different than the general population, that addictions, gender, income are much more of precipitating factors than any mental illness. Of course, the role of the media, as Patrick talked about this morning, of reinforcing these stereotypes, and the work of Otto Wall and George Gerbner really has clearly identified this. Ultimately, for the media, sensationalism sells newspapers, it sells movie tickets, and the question is, how can we go about, again, changing these approaches? Questions around discrimination and social distance. Over a third of Americans are unwilling to be friends with a person with a mental health difficulty. Almost 2/3 don't want a person with schizophrenia as a coworker. Over 2/3 are unwilling to have a person with depression marry into their family. This is where really the rubber hits the road in terms of people's lives and the impact that stigma has. As Patrick talked about as well this morning, the internalization of stigma, the embarrassment, shame, isolation, hopelessness that this brings. And that, again, the Surgeon General's report identified that what it does for help-seeking behavior, as well as the policy implications around insurance coverage, et cetera. Just a research that was released 2 weeks ago showed that impacts of stigma can also exacerbate depression symptoms, particularly around alienation as one key factor. This is an interesting slide about where do Americans go generally for mental health help. Family and friends foremost, general primary care docs, therapists, and minister, priests, and rabbis. Formal mental health systems are pretty low down the road. Again, in terms of other factors around public awareness, depression is the #1 mental illness that the public has heard about in the news, television, or movies. Clearly, pharmaceutical advertising has played a major role over, again, the past 10 years. And 56% of Americans cite that they know somebody with a mental illness. Majority of Americans see the media as ridiculing people with mental illness. Again, 84% show that state that people with mental disorders are targets of ridicule, that they're often shown as sad and lonely, rarely shown as being in recovery or as productive members of our society. So this is the heart of what I'm going to talk about. What have been our current activities addressing discrimination and stigma? And I'll talk about each of these in brief. The first is our Research Center to Address Discrimination or Stigma. Of course, in all bureaucracies, we love our acronyms. So this one is called the ADS Center. The ADS Center basic goal, again, following up from that 2001 meeting, to try to meet the needs for people for information about how to address stigma and discrimination. So in providing practical assistance for folks on how to go about doing that. In essence, it's meant to be a central repository and clearinghouse on information about stigma and discrimination, research findings, information about local, national, and international campaigns, et cetera. The particular target audiences for the Ad Center work are individuals, states and local communities, government and public-private organizations. These are some of our services, which I'll talk about briefly. First is a website, and the website is on the bottom there, www.stopstigma.samhsa.gov. And again, you can read for yourself some of the information that we have on the website. It includes information also about particular segment audiences, such as housing and landlords, employers, that we want particularly to get information to. The website also includes information about training announcements and a speakers bureau as well that we operate. We provide specific hands-on technical assistance to assist groups and individuals in starting these kind of work. And again, this is available either through the telephone or through the email. Telephone number is listed there. Also, in the resource room back at the other building, I brought a bunch of brochures describing the Ad Center. And it kind of looks like this. So I encourage everyone to take a look at the Ad Center brochure there. One of the most popular efforts has been a series of training teleconferences, which are free of charge and interactive, that we host looking at stigma and discrimination and providing information about how people can address certain areas. For instance, we've done them in working with faith and community groups. We also have done them with criminal justice, housing, as well as we sponsored one last year looking particularly at college efforts. All of these teleconferences are archived on our website, so people can go back and take a listen to these calls. They've averaged, as I mentioned here, about 250 people from around the country participating on these bi-monthly conference calls. This is a little bit more about these calls, again, and what their focus is. This past February, we did one specifically looking at secondary school settings. 137 people participated in that. And the next one is actually going to be in April, mid-April, where we're going to look particularly at addressing stigma within African American communities, and a whole series over the next year looking at different cultural, race, and ethnic groups. Again, you can find information about these teleconferences at the website listed there. We also maintain a database of research findings on addressing stigma and discrimination that's accessible and searchable. We also publish a newsletter, information updates, that's sent out electronically. We host a listserv for information on stigma and discrimination, again, that people can sign up for at that website as well. So that's a little bit about the Ad Center program. The second is a measure really trying to put the idea of contact into practice. and that's through organizing a series of consumer dialogue meetings. And as is mentioned here, it's basically a contact approach to impact negative attitudes. These are facilitated roundtables with consumer representatives and those from other groups. We started with mental health professionals, but since then, we've branched to include these dialogue roundtable meetings with faith organizations, criminal justice, co-occurring, and primary care issues. Our next dialogue is going to focus on college-age students, as a matter of fact, and we hope to organize that this summer. What's been interesting about this is we also have done some evaluation looking at the effectiveness of these kind of models. And although we've sponsored these at the national level, groups have taken these and replicated them on the local levels. And in fact, we've got a guide that can assist groups with organizing these kind of dialogue meetings. The University of North Carolina, Professor Anna Chayette, School of Social Work there, replicated this kind of a model with her social work students, where she organized a dialogue meeting. And these are usually two-day affairs. We keep them relatively small in number, about 20, 25 people in total. She organized a similar dialogue with consumers and her students, did a pre and post evaluation, and it showed marked improvement in terms of the attitudes of the students in terms of addressing stigma issues. We've also had some concrete outcomes come out of these dialogue meetings, including a training videotape for psychiatric residents. A lot of consumers expressed that the most important needs that they have when working with psychiatrists is around communication skills, and that relationship is so crucial. So out of this particular dialogue, we developed an 18-minute training video for psychiatric residents using consumer and practitioner views. The third effort that we're focusing on, and I'll spend a few minutes on this, is the Elimination of Barriers Initiative project. This is a 3-year, 8-state demonstration project looking at evaluating the effectiveness of particular approaches in addressing stigma and discrimination. We're looking at particular target audiences for the EBI effort are the general public, employers, and secondarily high school administrators and teachers. Through each of these state-based campaigns are using a multifaceted strategy. And that's something, probably one recommendation that's clearly come out of the work is you can't just do a PSA campaign, you can't just do a contact approach, you can't just do a protest strategy, but it really does need to be taken at a multifaceted approach. These are the pilot states. They were chosen for geographic diversity, population demographics, as well as a range of state development addressing stigma. For instance, Pennsylvania has a long history of addressing stigma and discrimination. North Carolina is still pretty much on the initial stage. And then as these states have been doing their work, we've been evaluating, tracking both the process as well as the reach, awareness, and utilization of the materials and approaches that they've been used. We're in our 3rd year of this particular effort. These are a few of our initial findings. And this kind of also repeats a little bit about what Patrick, our first attempt in developing messaging for this campaign really focused on finger pointing. You shouldn't use pejorative terminology. So we had developed storyboards for the PSA work that showed like psycho, crazy, nuts in big letters. And again, the feedback that we got, we did a series of 24 focus groups around the country, and this was done through contract with the Gallup organization. And again, the concern about rebound effect, that in fact we may be reinforcing these concepts. We also, through these focus groups, found similar findings about the use of celebrities, that the general public as a whole see this as an us-them situation, that celebrities may have access to more resources, but they're not like my neighbors. What we came back to then through the focus groups was, again, more of a normalizing message. And the overall theme of the campaign is up in the right. Mental health, it's part of all of our lives. And very much a strength-based, recovery-oriented message. We also surveyed the groups for language, and this was a really interesting one as well. And again, what we found through these kind of social marketing efforts is you have to be where the audience is. And when we tested the terms mental illnesses overall, people did not respond to that term whatsoever. And in fact, people would disassociate and not respond to a call to action when they heard that term. And many of us in the mental health community did not support that necessarily effort, but again, it's being where the audience is. What did tested much better was the concept of mental health problems, and what we're using in the PSAs is that term, mental health problems, and then underneath that, the term mental illnesses when people get the other fulfillment material. Again, the kind of public information that we provide here through this campaign, PSAs, all of the talent for these PSAs are consumers themselves. Drop-in articles featuring consumers' stories of recovery for local press. We're also doing another piece of work looking at this issue of self-disclosure. If contact approaches are to work, people have to identify, come out of the closet. Some have argued maybe we should have a national coming out day for consumers like ourselves. But again, there's risks and benefits involved with that. Bilingual brochure, website. The PSAs, again, direct people to get more knowledge and understanding, get more information about mental illnesses. It also provides people a link to our services locator that, where people can find information about treatment in their local areas. I have a copy of the TV PSA with me on VHS, and I'll leave it back over there at the resource room. I see that there's a monitor set up over there. If anyone wants to see it, these are 1-minute spots in English and Spanish. In short, it shows, and I'll read just a little bit of the text here. What do a hardware store owner, a mother of 3, and an honor student all have in common? They're all contributing members of our communities and all have recovered from a mental health problem. Mental health problems affect nearly every family in America. The Spanish language versions are a little bit different in that it shows a multi-generational approach and a doctor rather than a hardware store owner. Radio PSAs are similar. They're ones targeted to workplace, family, and school in English and Spanish. And again, the print PSAs have a normalizing message. You probably can't read that from the back, but what it says is every day someone with a mental health problem pops the question, earns a promotion, makes the grade. Again, very much trying to normalize these issues. The website, and again, I encourage people to take a look at it. They can download materials from that, as well as access our treatment locator. Some of the state coalition activities, and this is both meant, this campaign, both to be from a top-down as well as bottom-up effort. A lot of the states are doing media outreach. Ohio has a Student Speakers Bureau effort, and Pennsylvania is particularly targeting college students right now. Initially, PSA placements, since this has been released in May, have been very promising. Over 200 commitments for over 200 million images, just within these 8 states alone. It's been kind of tough because we've had the Olympics and the elections over the past year, but we've been very promising with some of those results. Again, the radio has been similar. This is all donated advertising, by the way, no paid advertising. Schools materials as well have been developed. They've also been targeting particular audiences and messages here. Mental health is part of all of our schools. Elimination of barriers to learning, very much tied to school performance and the No Child Left Behind activities as well. We found teachers to be very hungry for this information. And I'm skipping around here because I'm running out of time. We've also developed these business materials. I'll kind of quickly go over that. We're also doing a Voice Awards event in September where we're recognizing, in addition to protest strategies, you can also do reward strategies as an incentive for media to do positive portrayals. And this is an event in July, actually, and nominations are currently being accepted by anyone, again, at the website there. Two other quick mentions is we have a grant announcement on the street right now with our colleagues at NIMH, and this was a program announcement issued last fall to encourage applications between researchers and community groups to do more outcomes research related to strategies to reduce stigma and discrimination. Again, if people, or this would be an ideal way for universities and community groups to partner for this particular grant opportunity. Finally, our national anti-stigma campaign that we're just getting underway there. Again, the Commission's report first recommendation was a need to overturn stigma and discrimination and called for us to advance a national campaign. This particular campaign is a partnership with the Ad Council, which I'm sure many of us know, leading public service advertising agency in the country. And this is really building on the results of the Elimination of Barriers initiative. In addition to a general public audience here, specific sectors, and again, the Commission's report felt the need to target older adults, ethnic and racial minorities, and rural communities in particular. What I'll kind of end on is that I talked about a little bit about my roles being a consumer bureaucrat family member, but my most cherished roles are being a husband and father. I have three children. I have twins who are 5.5 and a baby girl who will be 1 year old tomorrow. So I'm leaving tonight to go spend her birthday with her. But a funny story, when I started at CMHS at SAMHSA 10 years ago, and I was the first self-identified consumer hired by that agency to do this kind of work. That's telling in itself that it took so many years to hire a consumer, but before I came, my wife was also working at that agency, my soon-to-be wife. And she's a nurse by profession, and she made a dedication to herself. She was expecting this consumer to come in drooling at the mouth and not being able to articulate well. And she was going to make it her commitment that she was going to take care of this person. Well, 3 years later, we got married, and again, live very happily in our community. Again, I want to thank you all, and best luck with the conference.
I think we have had a wonderful discussion of this topic. We do have time for a few questions before we make our way back over to Rackham. The first question is, the SAMHSA regulations are now being written for the Garrett Lee Smith Memorial Act, formerly called the Campus Care Act. Will grant funds for stigma reduction on campuses be considered for this?
That's a little too early to say at this point. It also depends on the appropriations and the funding that we ultimately get from Congress, which really dictates a lot of what we do.
Could you comment about how the health insurance models and the lack of parity between medical and mental health issues is being addressed in the anti-stigma program?
Well, clearly what we're trying to do is address the general public through a lot of these messagings. A lot of the states are also educational campaigns with their state legislators. We can't do specific lobbying as a federal agency, but on a state basis, a lot of the coalitions and advocates that we're working with are trying to affect this kind of change. Just as a side note around parity, as a federal employee, I have parity for my mental health coverage. And that was codified about 5 years ago. We're undertaking now research to look at that. Again, the cost is very minimal that's shown to date.
If the anti-stigma campaigns that you've described are successful, how do you anticipate that the national mental health care system will provide the services which this will generate? Does your agency or anyone else have a plan?
That's an excellent question, and one that we struggle. I mean, if we try to increase the demand, in essence, through this kind of work, is the supply there? And what we feel is ultimately that the demand will drive the supply. That if we can put enough education and encouragement to state legislatures, to federal governments and others, that the supply will ultimately come to be.
You mentioned your own personal journey through this issue of stigma at work. There's a question here about what strategies did you find successful in attaining the position you now hold? What approaches did you take to overcome stigma?
Key for me was family and friends and having that personal support. I mentioned already about the peer support groups played a crucial role in doing that. I still get feelings of stigma when I come to meetings and I'll identify myself as a consumer and have people literally turn their back on you. Some of that is, you have to find. I've also been in jobs where I worked there 5 years, and people, no one ever. A lot of this is not like blatant, but it's underneath. No one ever asked me to lunch after 5 years. I take that as part due to stigma. Part of that is having those support networks outside in the community, which has been really. Those of us that work in the federal government has its own pressures as well, but having those support systems is vital.
Do you think that the pharmaceutical industry's media campaign to sell drugs has minimized the public's perception of the true nature of depressive disorders? In other words, might the public trend to trivialize mental illness based on the quick fix results with drugs or experiences depicted in the campaigns from the pharmaceutical companies, do these adversely affect the perception or stigma issue?
Yeah, it's not one that I've considered before, but if you think about some of the advertising of cartoon figures and things like that, one certainly could draw that conclusion. There also is this issue, and I know this conference is specifically focused on depression, but many of us talk about there's a hierarchy in terms of mental illnesses, and while perhaps pharmaceutical advertising has done a lot in terms of depression in particular, many of the other mental health problems that people experience, haven't been really addressed.
Thank you very much, Paolo. We should go over to Rackham now for the next session. Thank you. Really good. Thank you.
Sure, happy to do it. Yeah, very much so.